Hey everybody, we're just spooling up on our various platforms. We will start the show in a minute. Hope you have a chance to join us tonight, and we got a great topic as usual and lots of questions to answer, so we're looking forward to reaching out and starting off the new year. So we're going to talk tonight about the risk of fetal harm with letrozole in fertility treatment. So basic background behind this is that letrozole is a medication that was initially used to reduce estrogen levels, mainly for breast cancer protection and treatment after women, especially young women, had had breast cancer. Dr. Bob Casper and Mohammed Mitwali pioneered its use in women to try and see if it could make them ovulate, and found out that it could, and then it became kind of more and more used for patients who had polycystic ovarian syndrome. So several years ago, back in I think 2008, a Canadian group from Montreal said maybe it is causing fetal malformations, and conducted a study where they showed that there is about a 4.7% risk of fetal anomalies with letrozole versus just a 0.8% in the control group. And the problem was their control group was just regular patients with no fertility history. And that's not really a valid control group, because we do know that infertility patients have a higher chance of anomalies. So this study actually took all of the studies available on letrozole, pooled all of the ones that were valid, and then analyzed them to see if there was actually a risk. So that's what we're going to be discussing tonight, and I want to go through that data with you briefly, and then we can get to the questions that everybody likes to ask on the show. Are we good?
Except for Facebook. Facebook's being a bit
Problematic. Instagram?
No, you're on Instagram.
All right, so we're going to keep going. Facebook friends, hopefully you'll be able to watch us shortly, but it's being tricky right now. So this is coming out. Its new article has not yet been published. It's coming out in Human Reproduction Update. The name of the lead author is Jyotsna Pundir, Pundir. And again, it says yet unpublished. So what they did was they analyzed all of the studies out there that evaluated the use of letrozole in comparison to any other drug or placebo, and had information on fetal outcomes. And there were 888 articles that they started with. They narrowed it down to 893. They wanted full text articles, so that dropped it dramatically down to 227. And then they had to exclude quite a number for problems with the articles. So they ended up actually at the end of it all with 46 studies that they felt met their inclusion criteria. And in the quantitative part of the meta-analysis, there were 39, 18 were in randomized controlled trials, 21 were in cohort studies. So still a lot of data in there. Lots of trials, lots of data, and so a good job overall in terms of what the numbers were. So the first thing that they looked at was comparing Clomiphene use to letrozole. So is there a difference if you took Clomid versus letrozole? Because now you're kind of doing an apples to apples comparison with most likely women who, the majority of whom would have had polycystic ovarian syndrome, maybe sometimes unexplained infertility, although neither of those drugs work alone for unexplained infertility. And there were quite a number of studies, both in randomized controlled trials and in cohort studies, and neither of those groups showed any difference in terms of the risk with letrozole use. So compared to Clomid, there's absolutely no statistically significant increase or decrease. And in fact, not a single one of the studies that they included showed any difference whatsoever. And so there was eventually no difference in the randomized controlled trials. When you look at the cohort studies, which are not as valid, but still they tend to be bigger with greater numbers of patients, there were 2 studies that just barely met significance for showing actually a decrease in risk in letrozole compared to Clomid. But overall, they said that there was no statistically significant difference. So we know that letrozole is a better medication to use for PCOS. And so in this particular sort of evaluation, it's demonstrating that there's actually no significant difference. You can use either one and you're going to get the exact same result. And that's from a safety perspective. From a pregnancy perspective, Letrozole has a 27.5% live birth rate after 6 months of use, whereas Clomid has a 19.1% success rate for live birth. So Letrozole is more potent in terms of pregnancy, but it has the same exact side effect profile in terms of fetal risk. So then they compared the Letrozole use to just natural conception. So these are infertility patients, but who are trying naturally. And again, they showed absolutely no difference. And this was actually a randomized controlled trial. And then in the 2 cohort studies that they looked at, again, there was absolutely no difference, although one study did show that there was a lower chance of an anomaly with Letrozole. But nevertheless, they said overall there's no statistically significant increase or decrease in Letrozole compared to patients that are not taking any medication, which isn't quite placebo, but is close. The next group was looking at the injectable medication. So what if you need the injections for your fertility therapy? And again, they showed absolutely no difference in the 2 randomized controlled trials. There were 6 different cohort studies, and all of them lined up almost exactly on the center line, meaning that there is no difference again between injectable meds and using Letrozole. So either way, you're going to get the same risk of fetal abnormalities. And keep in mind that the background rate of fetal abnormalities in fertility, without fertility, is about 2 to 3%, and it's typically up a tiny bit when fertility is part of the problem. So then they also looked at comparing natural cycle assisted reproductive technology. So this would be IUI or IVF, and they wanted to compare that to the patients that were taking Letrozole. And again, they showed absolutely no difference. So these authors basically said, look, there's no difference in the chance that the infants are going to be born with any abnormalities. It's the same outcome. Letrozole does not appear to pose any significant risk. But then they went into it a little bit further and said, well, what if we look at things like live birth and pregnancy loss and things like that? So when they assessed those, they showed that for pregnancy loss, there was maybe a slight decrease when you're using Letrozole. And same thing for live birth, a very, very small increase when you're using Letrozole. And so good results overall when they compared it to Clomid. So they were actually saying that your pregnancy loss may be a little bit lower, equivocal because the randomized controlled trials didn't show it, but the cohort studies did. And then for the live birth, they're saying it's a smidgen higher, which we already knew. So this is further data supporting that. So if you're comparing Letrozole to Clomid, it looks like your chances are better of continuing to be pregnant and getting pregnant. And they looked at the major malformations and saw that there was no difference in risk. When they compared Letrozole to the injectable medications, they saw absolutely no difference for pregnancy loss or for major malformations. And then when they compared it to natural conception, they looked at major malformations. And again, as I mentioned before, there was no significant difference. And when they looked at pregnancy loss, there was also no significant difference. So taking Letrozole versus natural, it actually looks like you have the exact same outcome as far as miscarriage risk is concerned. They then also looked at natural cycle assisted reproductive technology, again, whether it was IVF or IUI, versus the Letrozole. And there were one study that was included there, which did look at that. And in that study, they actually showed a 10% decrease in miscarriage rates when you're using the Letrozole. Now, many of you hopefully have watched our previous episodes where we use Letrozole as part of our frozen embryo transfer protocol now, because there are lots of studies supporting the use of that. And so we've built it into our program, and the pregnancy loss hopefully is going to be lower with that, because that seems to be part of what we're seeing in these studies as well. So overall, it appears that number one, Letrozole is effective. Number two, it's potentially more effective than Clomid, and that's being borne out in both this study and a previous very well done randomized controlled trial that was published in the New England Journal by a gentleman by the name of Legro, Legro. And that's where that 29 versus 19% comes from that I quoted earlier. And then on top of that, the chances of miscarriage appear to be a bit lower as well. Are there increased risks of malformations? No, there definitely does not appear to be any increased risk of malformations when you're comparing letrozole to any other fertility treatment that is available. So whether you're using natural, whether you're using Clomid, whether you're using injectables, or even natural with assisted reproductive techniques like IVF or IUI, you're going to get the same outcome, which is great news because letrozole is now recommended as the first-line therapy for PCOS patients. And we certainly don't want any of you to take something that isn't safe. We want you always to take medications that are safe, are going to result in a positive outcome for you, and it result in a safe outcome for you as well. So is it a fact or a fiction that letrozole causes fetal malformations? It is a fiction. There is no evidence supporting the concept that letrozole actually increases your risks of fetal malformations when you use the correct control group, which are other patients with infertility or other patients who are suffering from infertility and or undergoing treatment. So make sure you like, comment, and subscribe. We always want to see how you guys feel about this. Let us know your experiences. If you've used letrozole, did you have any children with any complications? Certainly share with us all so that we can bring that to the rest of the group and the rest of the community and make sure they know about what happened to you. And we want to hear from you about what you thought of this video. So let us know. Just click on that subscribe button and we'll be happy to bring you on board. So we're going to go to the question section now and we'll start that part off. And I think we have lots of questions, although some of them were directed at me because I put up a post for people to know about me, but I'll answer those on Instagram. So you have some questions for us, Stark?
Yeah.
Did we get Facebook up and running?
No.
Oh, really?
Yeah,
That's not good.
Facebook's not participating. But we do have some questions related to the today's show right now.
Yeah.
Let's start with that. What are your thoughts about combining letrozole with Clomid for an Iui cycle?
Yeah, so there's actually some data that supports that for patients that fail letrozole alone, combining letrozole with Clomid can do better. I've actually seen one study that supports that. It's not a huge study, so it's reasonable to consider. I've never actually done it, but it can be done. Typically, the reason to do that is if you're failing the letrozole, but you do have a range of different dosages you can work with when you're using letrozole, up to 10 milligrams. And then there's all of the other factors that you need to include. So we use all of the natural supplements like inositol, NAC, coenzyme Q10, DHA, which are the omega-3 fatty acids. You may need to use metformin to help you as well. And then lifestyle modifications if you need them. If your weight is part of your PCO, then for sure you'll want to focus on using that as well, which includes eating 1,500 calories or less and eating that across 6 meals a day. And then on top of that, making sure that you do your exercise, and that has to be muscle building exercise. So people tell us all the time, oh, I'm walking all day, I'm working, I never stop. That's simply not exercise. I work all day too, but if I don't exercise, all these Lindors that I have hanging around here will finally start to add up. So you have to exercise in order to get the muscle to build up in order to be successful.
What does letrozole make? Why does letrozole make your body ache?
I don't actually know why letrozole makes your body ache. It's actually a fairly rare symptom. Not all women get that, although it does cause some arthralgias or myalgias in some women, which are joint pains or muscle pains. Pretty uncommon though. That's not something we get as a common side effect. If you're having that, you may want to use a different medication like Clomid, or maybe go up to the injectables if it's really bothersome for you. You can always take Tylenol. There's no harm from Tylenol when you're trying to get pregnant. But avoid ibuprofen because that actually can interfere with your ovulation if you take enough or take it at the wrong time.
Can gonal F cause abnormalities?
No, there's no evidence whatsoever that any of the gonadotropins cause abnormalities. Keep in mind that all of those are actually mimicking your body's own hormones. So gonal F is just a sort of copy of what you normally make for your own FSH. So it's not going to cause any fetal abnormalities. You're just making more of what your body makes on its own. IVF, especially with ICSI, has been shown to slightly increase the rate of fetal malformation, probably by about 1 to 2%. So you go from 2 to 3% to 3 to 4%. So it's important to recognize that number, but it is not because of the gonal F, it's actually because of the IVF treatment with ICSI. But the percentage is so small, we don't generally get concerned about that. And I've actually only ever seen one fetal anomaly in all of the babies that we've had. So it's pretty uncommon for us to see that. Next.
What causes abnormal eggs when chromosome test is normal in both partners?
Oh, well, so the chromosomal testing for you can be completely normal, but that doesn't mean that your eggs, or your sperm for that matter, if you're male, is genetically normal. You can still have abnormalities because in order to make your sperm and your eggs, your chromosomes are actually pulling apart originally, at least when you're female, in order to make the eggs, and for males on an ongoing basis. During that division, abnormalities can occur, and so you can have abnormal eggs and abnormal sperm, and the number of abnormal eggs increases with time. So even though you're genetically normal, it by no means indicates that your sperm or your eggs are genetically normal. They can actually be quite abnormal, even though you're totally normal. So it's not correlated at all. I mean, obviously, if you have a genetic abnormality, there's going to be an even higher chance that your sperm or your eggs are abnormal. But if your if your chromosomes are normal, you can still have abnormal gametes or sperm and eggs. Yeah.
Menopure versus gonal F.
Oh, which one's better? So we actually use both. If you look at the head-to-head trial, there actually is one. When they originally released Menopure, they actually compared it to gonal F. And in that trial, there was no difference between the two drugs at all. Although there was a slight suggestion that Menopure produced better quality embryos, and a slight suggestion that gonal F made more. So we typically mix and match. So we use some gonal F and we use some Menopure. And there's a ratio that is optimal for that. If you look at another study that reviewed what the percentage was between the two to get the lowest number of genetically abnormal embryos. So we use it in the appropriate ratio to get as low a risk of genetically abnormal embryos as possible. But there's really no difference between the two. If I'm just going to use one, I'll use Menopure just because of that theoretical improvement in embryo quality. And if I'm going to go for making more eggs, I'm going to try and use the gonal F because it is a bit more potent. And now we have Recavel, which we also use, which also seems to be a really, really good product for women with weaker ovaries, as well as in general. Yeah.
So we still have Facebook.
Next?
Yeah.
Oh, don't shut down.
Okay.
Yeah.
Okay.
You can set up a camera. I can pop it up here if you want. You want to pull it
Yeah.
up on the computer and we'll just do it sideways?
Yeah, so I'm thinking something like that.
Yeah. Where's the mouse? Oh yeah, here's the mouse. You'll need that too.
Alright, so bear with us
Yeah, yeah. What's the next question?
Can Letrozole cause your cervix to be more sensitive? I've taken it for 10 months and been spotting for several days now. Also, I read that Letrozole can help suppress endo. How well does it work?
Okay, so to the best of my knowledge, I've never heard of anyone saying that Letrozole actually causes you to have sensitive cervix, although I guess it's possible, but it's not fairly usual. So that I've never heard of before, but I guess in theory anything's possible, especially if you're very hormonally sensitive. From the standpoint of your endo treatment, Letrozole can be effective because it reduces estrogen. Endometriosis is estrogen sensitive. So if you are eliminating the chances of the estrogen being high, you're decreasing the chances of the endometriosis growing. So you can use Letrozole. It's not a sort of known established treatment for reducing endometriosis. We don't use it for that purpose, but it can be used in that way. And we do use it if you're getting ready for an embryo transfer and you have a history of endometriosis. There's a very well done study we actually reviewed on Fact or Fiction a while back that showed that if you took Lupron for 3 months with Letrozole and then did your embryo transfer, 3 to 6 months actually, that your success rate was higher. So we do that for all of our endo patients. Typically we'll put them on Lupron and Letrozole, and then between the two we get a really good success rate that helps with everything.
Should I keep taking Letrozole because it did regulate my cycle, but I haven't been able to get pregnant? I have PCOS, don't get my period without it.
Yeah, so if you have PCOS, you may have seen my Instagram post and Facebook post the other day, which said, is it safe to not have a regular period? So it's 100% not safe for you to have an irregular period. You must have a regular period. So if you're getting a regular period on the Letrozole, you can take Letrozole indefinitely. It may not be sufficient to get you pregnant, and if that's the case, you may need to look at alternatives. But if it's at least keeping you regular and you want to stay regular, your choices are the Letrozole, the natural supplements, which can work on their own, metformin, which sometimes can work on its own, or take the birth control pill if you're not trying to get pregnant. And that will keep you regular at least and protect you from the cancer, the depression, the heart disease, the diabetes, all of that stuff.
Hi doctor, I'm 42 with low AMH. I got a Lupron 3.75. Why they injected ITME? I have a very regular period.
I'm not sure. It depends on what you're doing. I don't have quite enough information there. So you may have gotten Lupron because of endometriosis, like we just said. You may have gotten it because you were getting ready for an embryo transfer. Some people use it for IVF, so it depends. Although if your AMH is, if what that number you gave me is in picomoles, Lupron would probably not be ideal for you unless they're using microdose Lupron. Then it's definitely usable. If it's in nanograms per mil, they may have been using it, but that's just preference. You can use an agonist or an antagonist protocol, and that would have been an example of an agonist protocol.
How do Clomid and Letrozole work differently in the body? Are they both aromatase inhibitors?
Aromatase inhibitors.
E2?
Yeah, so they are various types of medications that can stimulate your follicle to grow. They do work differently. Letrozole works by essentially telling your brain that you don't have as much estrogen, so your brain sends out more FSH. Clomid is an inhibitor or a selective binding chemical compound, and in doing so it actually makes your brain also think that you don't have enough estrogen, so it actually stimulates it to put out more FSH and drop your LH levels. So they do work differently. They're not both aromatase inhibitors, but they do end up getting you the same outcome at the end, which is to stimulate more FSH, which then lets you produce more follicles and hopefully mature the follicle enough to get it to release, which typically doesn't happen with PCOS patients.
How long should I wait to get my period again?
Well, your period should be less than every 35 days. So if you're taking Letrozole or Clomid or whatever and you haven't had a period in 35 days, you first do a pregnancy test. If your pregnancy test is not positive, then first of all, I'm sorry. Then you take Provera for 10 days. It should induce a bleed, and then you start again.
Hi, Dr. Victory. I'm wondering if you can talk about injectable medications and potential increase of risk for female cancer.
Oh, yeah. So there's actually lots of studies done on this, and not a single one has actually supported the idea that the medications increase your risk of cancer. Infertility does increase your risk of cancer. In fact, in one study from Stanford with over 12,000 women in it, they looked at this, and even if the fertility problem was from the guy's side of things, it still increased the risk of cancer. But if it was from the female side of things, it was also an increased risk for multiple different types of cancer. So there is an increase in risk, but it's not from the medications. So if you need to take the shots, you can take the shots. Now, obviously, if you have a strong family history of breast cancer, do you want to be taking tons and tons of estrogen-producing medications? No, but for the brief period of time during which you're taking it, it's safe. And actually, many studies show that getting pregnant and having a baby and ideally breastfeeding are some of the most significant things you can do to reduce your chances of breast cancer. So that brief period of estrogen increase is well worth it if you can get to the other side where you're having a pregnancy, because that pregnancy is going to drastically reduce your risks. Do you need me to do something?
Her live's over.
It's about to go live. Oh yeah, there we go. Yeah. Fire.
Okay. Is Lupron to make does Lupron make birth defects, or is Lupron, I don't know.
Does Lupron cause birth defects? No, not at all. Zero. Oh, we're finally live on Facebook. Hello, Facebook friends, when you join us. Yeah.
I have been on Letrozole for more than a year now. Made me ovulate, and I got my period every time. Unfortunately, no pregnancy though.
Right. Yeah, I mean, Letrozole doesn't cure it, right? So there are other things that you may need in order to get the Letrozole to be successful. So it doesn't always work with just Letrozole. You may need to use diet. You may need to use exercise. You may need to use the supplements I mentioned earlier on. Some people need additional medications. You may need metformin. Sometimes you need insemination. It may not even be you. You may need insemination to help you. You may need to use all sorts of different things. Hi everyone on Facebook. Sorry, the new system was locking you out, so I apologize. You'll be looking at my side view because we got two cameras going on at the same time. Yeah. We're taking questions though, so feel free to jump in.
What is your experience with normal sperm count but high DNA fragmentation? Why is DNA fragmentation testing not part of the initial workup before the first IVF visits?
Yeah, so we don't always do DNA fragmentation if the sperm looks normal, because it's pretty rare to have high DNA fragmentation if the sperm is okay. It's certainly possible, but we don't see it typically. So in order to save people money, we don't always do the sperm DNA fragmentation test. I am starting to build it in more and more because I am finding more and more men that have problems, especially after the holidays where smoking and drinking and drug use and the COVID lockdown have increased all of that. It may be quite reasonable to screen people for it. So we are doing it a little bit more. The main thing behind sperm DNA fragmentation is that it actually is known for sure to increase your risks of miscarriage, and it may additionally increase your risks of poor fertilization, poor blastocyst development, poor embryo quality. They're not as sure about that, but they're quite sure about the fact that it's a very significant increase in miscarriage risk, up to 1,200%. So we actually have a fertility factor fiction on that from over a year ago. You'll find it on the YouTube channel. And so you should go there and take a look. Make sure you comment, like, and subscribe. Smash that subscribe button and then you know, take a look there and see. But we reviewed that. So DNA fragmentation is important, but we don't do it for everybody because if the sperm quality looks good, it's unlikely you're going to have high sperm DNA fragmentation. Having said that, probably more and more it should become mandatory as part of an IVF cycle because you want to know ahead of time, because you can improve the outcome without, you know, or before I should say, going into the IVF. I got a question here from Tisha. 8 weeks pregnant with twin, had 2 subchorionic hemorrhages, 2.5 by 1.5 by 2 centimeters, and 1.4 by 1.1 by 1.1. The cervix is closed, but on my bed rest, the doc didn't give you any meds. I need the mouse, it's here. Should I be concerned about miscarriage risk? And should I get any meds? Yes, you should be on progesterone. You should be on progesterone. So you need to be on progesterone for sure. If you have that much of a bleed, especially with twins, you want to definitely be on progesterone to keep the uterus quiet. No smoking for sure, no drug use, no alcohol. I would take it very easy, especially with a twin pregnancy. That's going to be important. With a 30 to 31 day cycle, when would I recommend you start testing for ovulation? So your ovulation always occurs 14 days before the start of your next cycle. So in other words, if you're a 30-day cycle, it's typically going to be around day 16. If you're a 31-day cycle, typically day 17. So you should probably start testing around day 13, maybe 12, 13, just to make sure you don't miss it, and then go through it and get it to the point where, you're getting it to almost, 17, 18 is probably the farthest out there you'd need to go. Maybe 19. I think that's probably going to be in the field of view, isn't it?
No, I don't think so.
Okay, go for it.
How is taking a trigger shot beneficial for someone that ovulate normally?
Yeah, so there's a study from Hamilton that we actually reviewed, I think it was last winter or early spring, that showed that if you took a trigger shot with your Letrozole or Clomid, or even if you ovulate naturally, that it actually increased your chances of success significantly. So that's why we do that for everybody now. Yeah, so taking the Letrozole definitely makes things better and increases your chances of success. Yeah. So we do it for everyone now regardless.
I am 45, had 5 miscarriages with own eggs.
Ooh.
Then did a double donor and still had a miscarriage.
Oh,
Had laparoscopy 5 years ago to see if I had endo and didn't.
yeah.
Could have it now, 5 years later.
Not at 45, it would be highly unlikely. And endo doesn't typically cause miscarriages, it causes failures to get pregnant. You need an infectious workup, a thrombophilia screen where we look for blood clotting. You need your vitamins checked. You need your thyroid checked very carefully, especially for antibodies. You need to check your weight because that can do it. If you smoke or drink, that can be a factor. Or marijuana use. You need to have infectious screening from inside your uterus. We do that through Fertility. They're a great company for looking at that. And then you need your embryos tested for genetics if you're having miscarriages of donors, because there's something definitely unusual there. Plus you need a very careful look at your uterus to make sure there's no fibroids, polyps, abnormal shape, whether it's indented at the top like a heart shape, a septate uterus, or maybe a T shape or a Y shape. All of these are important to look at. I got one here. Late to join tonight, so I hope this wasn't already asked. I'm curious what your suggestions are for pregnant women taking the COVID vaccine, since Ontario is opening it up to pregnant and breastfeeding women. In my case, I'm curious about how negative blood type and needing the RhoGAM shot will affect your suggestion. Oh. As far as we know, there's absolutely zero association with your blood type, so that should not be an issue. We are right now under the assumption, and it is an assumption to some extent, that the vaccine is safe. So the mRNA vaccines drop into your cell and make your cell start producing the antibody to the virus. That's all it does. It's not like integrating into your DNA or anything like that. It's just jumping in there and it's teaching your cell to make the antibody to the virus. So the antibody itself is harmless. And we know that because the natural antibody you produce to the actual virus is harmless because the women that have been pregnant and gotten COVID have no fetal effects or fertility effects. So that part's okay. So the vaccine immune response, which is producing this antibody, is also going to do the same thing. So that part's okay. We also know that up to 30 women, I think it was 28 women, in the Pfizer trial either were pregnant or became pregnant during the trial, and those women did not have any issues in their pregnancy, at least up to now. None of them have had any pregnancy problems. Certainly none of them had any miscarriages or anything like that that has happened. So because of that, we feel it's pretty safe, and actually Pfizer is starting the trial to get it running to do vaccinations specifically in pregnant women as part of a study very, very shortly. They're actually looking at us as one of those sites. So as far as we know, it is appearing safe, but there is no concrete evidence that it is. Breastfeeding though, I mean, it's not going to be risky for breastfeeding. There's no way it could harm anything in that way. You're passing an antibody onto your child at most, which you do all the time, every time you breastfeed, because that's actually a good part of breastfeeding. It's one of the best parts of breastfeeding is that you're actually passing your antibodies to your child, and that way the child is protected.
If I had a SIS done about a year and a half ago, I'm currently at a new clinic. Do I need to get one again?
A year and a half ago, I would probably say yes. That's a long time. And especially if you've been doing treatments, we would want to know if you've developed a fibroid or a polyp, or maybe you got pregnant in between, or someone did surgery. So yeah, it's pretty harmless. We have a great video on our YouTube channel of me doing an actual SIS on a patient live. If done properly, and I've posted on this on Instagram a while back, there's absolutely no pain. It does not have to be horrible. It does not have to be a terrible experience. It can be very gentle, very easy. So make sure your doctor follows the rules that I set out in that Instagram post, and take a look at that because it gives you all the info you need.
First IVF cycle resulted in 2 embryos, failed transfers, and early miscarriage. Another retrieval soon. Honest thoughts on how hopeful we should be that things will be different this time around. MFI only.
Male factor infertility only. So last week we actually reviewed a study which looked at if you didn't do great in one cycle, what happens in the next cycle. And so only 11.5% of patients had a repeat poor cycle outcome. So usually you'll do okay, but it all depends on how many eggs you produce, what your age is, how bad the male factor is, what quality embryos you're getting. But if you are able to make blastocysts, you need 3 genetically normal blastocysts in order to get a 95.2% chance of live birth. So if you can get those 3 embryos, that's fantastic. You're going to get there. And it might take a couple of tries, but as long as you can get that right number of embryos, you're eventually going to get to where you want to be. I've got one here. Hi, doctor. My question is constipation and gas affect the second month of pregnancy. Is the use of milk of magnesia considered safe on daily basis during pregnancy? Yeah, milk of mag is harmless. You can use milk of mag. It's fine. Yep.
I'm 12 days late. Never been late before with my period. Have lower back pain. My fertility doctor doesn't believe it's endometriosis, but thinks it's stress and possibly premenopausal. How can you distinguish endo from premenopausal?
So there's only one. That's a great question. Thanks for sharing. Everybody throw up some likes for that brave question. So there's only one way to actually detect endo, and that is to actually do surgery. So there is no way to detect endo without doing surgery. You have to do surgery. Having said that, low back pain is not typically the only symptom you'll get from endo. I mean, endo can present in many different ways, but it's typically not just low back pain, and it certainly has nothing to do with you being late. So I'd actually get checked, first and foremost for pregnancy to make sure you're not pregnant. And then as long as you're not pregnant, your options would be to try a medical approach to help distinguish if this is gynecologic or non-gynecologic. So let's say hypothetically you're not pregnant. You decide to take a medication that's very good at treating endo, either birth control or Visan or Lupron. You could try those, and then if they work, you're in great shape. If they don't work, then that probably tells you it's unlikely to be endo. It's not proof, but it's unlikely to be endo if you're trying those meds and you're not getting the outcome that you want.
Do you recommend antibiotics for a FET cycle? Why are they used for a FET but not an IUI?
So no one's ever looked at it for IUI. And IUI, the chances overall are fairly low. I mean, the highest chance you're going to see with IUI in a really young patient with injectable meds is probably around 20 to 25% that they will get pregnant from one individual IUI cycle. So even if you make a 2% difference, it's not that much of a difference overall in chances. But with IVF, especially with people spending so much money, we typically will do the antibiotics. It also has to do with how invasive things are and what we're doing and all the poking and the prodding and stuff like that. So it's obviously way more invasive when you're doing IVF than when you're doing IUI. So the chances of infection are higher, and you're putting an embryo in which has to directly implant. So we want that area really clear and free of bacteria. But with IUI, the sperm still has to go up, make the embryo is still surviving that whole pathway into the uterus. So if it makes it down there, it's got a pretty decent chance of implanting. So that's why we don't use it, although we certainly can. And we actually follow up our antibiotics now with probiotics, because there's lots of evidence that supports the idea that the microbiome, or the bacterial sort of makeup of the vagina and the uterus, actually has a huge impact on how you do with your fertility. So we're not just using antibiotics, we're using antibiotics and probiotics to get our chances to be as good as possible.
How long do you use letrozole during the FET protocol? Why use estrogen patches, pills, and FET protocol after using 2 months of
Lupron.
and letrozole?
You still need estrogen to thicken up the lining of the uterus in order to get it ready for an embryo. So even if you have endo, we still have to give you some estrogen. Now you could just go with your natural estrogen and hope that it thickens enough. We prefer to give you as much estrogen as we think you need while you're still on the Lupron to kind of optimize the whole outcome. But you're going to need some. If you're on Lupron for months and letrozole, it's blocking all your estrogen. If I don't give you some, your lining won't thicken. If your lining won't thicken, you're not going to be able to implant an embryo. I've got a question here. How fast does premature menopause work? And how do you know if it's progressing? So premature menopause can come on quite quickly. In some women, it takes years. In other women, by the time they're in their early 20s, they're already in premature menopause. So it varies. It's not like there's one standard where you say from onset to completion, it's 6 months or 8 months or anything like that. It can take years, or it can be very, very quick. It's rarely super quick where you're fine 1 month and then 3 or 6 months later you're in big trouble. But over time it can occur. The one exception to that is in women who get infectious premature menopause, where they get just completely wiped out, and that can be quite quick, or chemotherapy or something like that. That again can be very, very quick. So there are instances where it's faster, but if it's like a natural premature menopause, it's typically over months or almost a year or more. In terms of how can you tell if it's progressing, you can count the number of eggs and you can monitor your AMH. Those are probably the two best markers we have of how you're going to do with it. Yep.
Is there any issues with melatonin when trying, or if it has any effects on fertility?
Yeah, so we have a great fertility fact or fiction. If you just subscribe to the YouTube channel, you'll see it there. So go on our www.youtube.com/drvictory, hit the subscribe button, and you'll find the fertility factor fiction on melatonin. So 3 milligrams of melatonin per day actually does increase your success rate. So we have all of our patients on a whole supplement mix now to maximize their chances, and it seems to be working really, really well.
Do you use baby aspirin or hairpin with all FETs? Would it be wise to use it even if my doctor does not recommend using it? Thank you.
Well, I'm not sure I'd ever recommend that you do something that your doctor doesn't recommend. So I want you to always discuss it with whichever physician you have. But it's pretty much unequivocal now that aspirin has benefits in pregnancy and for fertility. So I use it, I believe in it. We use it for all our FETs, unless the patient has a reaction to it or something like that. But otherwise, yeah, we use it for almost everybody.
I'm on NFH, prenatal folic acid, omega H3, ubiquinol, and PQQ. I don't plan on starting IVF until after July. Do I continue taking all the vitamins plus the PQQ? Low AMH. Thank you for doing this. Yeah,
I would stay on all those vitamins. There's certainly no harm to taking vitamins, so I would stay on all of that. You may, emphasize may, want to consider taking DHEA if it's that far out, but start it about 3 or 4 months before. And aside from that, just stay on all the healthy stuff, healthy diet, exercise, acupuncture. Those kinds of things may help you. See a naturopath. We use Jen Strong. She's amazing. So you can always reach out. We can put you in touch with her as long as you're Canadian. Hi, Krista. How are you?
What did the study consider abnormalities to be? Physical or disabilities too?
It wasn't disabilities. It was congenital birth defects. So they looked at a whole list of different things. that they included in there, and I can go through it with you. But essentially, they were looking for any kind of significant fetal abnormality that was major, and it's in a supplementary table that I don't have on me here, but I can pull that up for you. Basically, major defects, heart defects, stomach defect, facial, club foot, limb deformities, that kind of thing.
Can metformin help with egg quality if you're on the lean PCOS spectrum, high AMH and AFC, but no irregular cycles or other symptoms?
Yeah, metformin might if you're lean PCOS and you have insulin resistance. But if you don't have the insulin resistance, it probably will not be of much benefit to you. So for our lean PCOS women, we only use the metformin when they do have actual insulin resistance. Abina on Facebook is asking what my thoughts of the Receptiva test are. It's useless. So the ERA test, the Receptiva test have absolutely no benefits whatsoever. They don't work. There are 2 new studies coming out showing again that the ERA test does not work. Their own study shows it doesn't work. No study actually shows that it does work. Receptiva is the same. Don't bother using it. It's useless. So I don't use either of those tests anymore. We only use the ERA test in someone whose lining is very, very thin, and we just can't get it to thicken. So that's rare, but if that's the case, it's maybe a worthwhile test, and certainly not for timing, only to tell me if it is receptive or not. I wouldn't trust the timing issue because it doesn't even make sense, and none of their studies show that it helps. So we don't do that. Yeah, so skip the Receptiva test. We are trying this new ultrasound-based test, and we're going to trial that out and see how that works. There are some places that swear by it, but we're still in trial mode. I've only done it a couple of times. One time it worked, one time it didn't. So I'm not sure yet. We'll see.
What do you do in a patient who doesn't respond to Menopur in AM, IM, and IVF cycle, and an IVF cycle?
So if you don't respond to Menopur, we'd need to know why. Either you were too suppressed going into it because you were on birth control or Lupron or something, you just can't wake up the ovaries, or it's because your ovaries are not working properly. So if the problem is your ovaries aren't working properly, we got to go back to the drawing board and look at the various options. And those options may include a different protocol. They may include supplements ahead of time, testosterone priming. It may include acupuncture. It may include different medications. So we frequently turn to Recavel if Gonal-F or Menopur are not working. We'll use a Lupron flare protocol. So there's different ways you can kind of try and trick the body into doing it. To be honest with you, the one I favor the most is just skipping that and doing a natural IVF cycle where you're just getting 1 egg, because a lot of times you do all these extra tricks and treatments and then you go for it and you end up getting the exact same number of eggs, which is 1. And so now you've spent a ton of time, frustration, and you got 1 egg when you could have gotten 1 egg without giving any of those meds. So it's totally reasonable to just do a natural cycle, IVF cycle there, or to try one of the other options, as I mentioned earlier. But that's typically what we do. We look at why it happened, and you've got to distinguish it into it's a protocol problem or it's an ovarian reserve problem. If it's ovarian reserve, your options are more limited. If it's a protocol problem, there's loads of different protocols to use. How do you determine when a lean PCOS patient has insulin resistance? You can just measure insulin resistance. Fasting insulin and glucose, there's a ratio you can look at. There's all sorts of different tests we can do to check you out and see how things are going. Curious if fertility procedures such as IUIs will still be offered during possible further lockdown restrictions to come. We're still going strong and we won't be shutting down. This place is the safest air quality probably in the city, if not in Ontario. It's so filtered in this building, it's crazy. So yeah, we're not going to be shutting down, don't worry. Do I have a waiting list for my clinic opening in the US? No, not yet, but we're working on that, so I'll let you know. Are we doing face-to-face appointments at the office or just over the phone? So we do face-to-face appointments in the office, although we try to limit them extremely because we want to minimize everybody's risks right now. So most of it is done by telephone or by Zoom. So I'm on Zoom like half my week. So we do that all the time, and we're very comfortable with that, and it's had very good interaction, so we can do that for you. Yeah.
No PCOS, but my doctor prescribed Letrozole for Iui for male factor infertility. It thinned my linings even with estrogen supplements. Any suggestions?
So if you have male factor infertility, Letrozole probably is not going to help you very much, because Letrozole at most will make you make 1, sometimes 2 eggs. So it's not benefiting you in any way necessarily, other than the maybe decrease in miscarriage risk. Cases like that, you would normally be better off on Clomid, except that you're getting a thin lining. So I would actually go to the shots. The shots will make you make more eggs, make you make more estrogen. Your lining will be thicker. So that's a better way to go about it.
Do you also deliver your patients' babies?
I do. So I love delivering my patients' babies, because I get to be there from egg retrieval all the way out to actually handing them their baby, which is one of the nicest things you can do. So I still do obstetrics, and I love doing it. So far we've still continued with that. It's really nice for the patients to be able to be there for them from A to Z. Most fertility specialists give that up. And I'd love to know how you guys feel. So tell me how you feel about that. Do you want your infertility specialist to deliver your baby? Make sure you comment on that, because I'd love to know. If you guys enjoy that kind of thing, then that keeps me doing it. And if it's not important to you, then I'd still probably keep doing it. But it's good to know, because we want to know how you feel about these things. So make sure you comment. Let us know what you think. I like the idea that I do everything. So I do all my own surgeries. I do my own fertility work. I do my own deliveries. So I love that part of what I do, because I can kind of do it all, and I get to be there through every step. And when I'm doing each of those things, I'm looking at it from the fertility specialist perspective, which is a little bit admittedly different. So I'm being very, very careful with my obstetrical patients. I'm taking extra precautions to make sure that my fertility patients don't run into any trouble based on their history. I'm making sure that if I'm doing surgery, I'm preserving every single thing to make sure that their fertility is preserved. So I'm not going to damage the ovary. I'm not going to be too invasive. I'm not going to screw anything up. So we're very, very careful about what we do and how we do it to always maximize the patient's fertility. And because that's at the forefront of my thoughts, I think it makes a difference into what we get as far as outcomes are concerned. But I would love to know your thoughts on that, guys. So put up the comments. Tell us how you feel about that. That would be hugely helpful for us.
Does continued Letrozole use negatively impact ovarian reserve?
Nope, not at all. You're not going to get any impact from Letrozole use on ovarian reserve.
Why do you have to have at least 3 miscarriages before seeing a fertility specialist?
You don't have to have 3 miscarriages before seeing a fertility specialist. You can come see us after 1 miscarriage. The issue is that it's common to have up to 2. Most of the guidelines now say that you can see a fertility specialist after 2 in a row, or after a mid-second trimester or even an early second trimester loss, because when they studied it, there's actually no difference in the yield from the tests that we do. If you've had 2 miscarriages in a row or 3 miscarriages in a row, we're still going to get the same percentage of patients that show up positive for something we can fix, or maybe not fix, but that will show up with something that will give us a diagnosis. So because of that, the sort of suggestion has always been to do 3, but now they've moved that actually to 2. But you can see us at any time. I mean, we don't put restrictions. It's not like we reject you because you want to see us. We got loads of patients that have 1 miscarriage and come in for counseling because it was really emotionally or mentally or even physically traumatic for them, and they don't want to go through it again. So we do that all the time. Is there an alternative to Flagelle? Can it cause vomiting? And what is safe for nausea and pregnancy? Flagelle can cause nausea. Some people describe that, so that's pretty common. Clindamycin is what we would use if the Flagelle is making you queasy. That's an alternative. And nausea, diclectin, Gravol, those are all safe. Maxiran, Stemetil if you're okay with it. So there's a bunch of different things. Zofran is probably safe as well. You delivered my sister's baby 12 years ago. Yay! I have implantation failure. Do I need to do a lap? You might. So you need to see your fertility specialist and discuss your implantation failure with them. If your implantation failure showed that you had everything perfectly normal and it still failed, you got to look at the embryo, you got to look at the chances that it was something about the transfer, you got to look about you. So whether it's endo or inflammation or smoking or a problem with your uterus or whatnot. So make sure you talk to your fertility specialist. We would certainly consider surgery for patients who have failed twice with a good embryo and everything else went well. I always tell patients that when you're dealing with an embryo transfer, there's three components. So there's the passenger, there's the passage, and there's the destination. So the passenger is your embryo. So if the embryo is normal, if it's healthy, if it's genetically okay, it's a vigorous embryo, it looks good, then that part of the equation is solved. If there's a genetic abnormality, if it hasn't been tested, if it's from a poor quality egg or it's very granular or not looking healthy, obviously that limits the chances. The passage is us, so we got to know how to put in a good embryo transfer. If you have a very difficult uterus, if the visualization is poor, if your uterus is retroverted and they're not doing a transvaginal transfer. Sometimes I've seen the ultrasonographers just reefing on the uterus. They're pushing so hard. You can't see anything under those circumstances and you're killing the poor patient. That is the wrong way to do it. People have to learn how to do transvaginal ultrasound guided embryo transfers, which we do all the time. And then you can see beautifully. You don't have to have that painful full bladder. You don't have to be uncomfortable. It's really easy to do and the success rates are the same or even better. So, you got to know how to do that passage part well. And then the final part is you. It's the destination. So we got to make sure that you're healthy, that everything is normal with your body. You don't have an immune problem. You don't have an infectious problem. The lining is good. It's responded to the progesterone. Your progesterone levels are appropriate. You're on all the right vitamins. Your immune system's not overactive. There's loads of things to check. So we do all of that.
What are the chances of getting pregnant right after Lupron if it put the endo on pause for a bit?
Well, I can't give you a specific number, but your chances would be almost equivalent to what they would be if you didn't have endo. So in an average couple with no endo, if everything else is okay, you're looking at like a 15 to 20% chance per month, usually more like 15 these days. So you'd probably be somewhere in that 10 to 15% range.
In your experience, what have been the most common cause of unexplained infertility if found with testing?
Most common cause is probably something you guys are doing wrong. And I don't mean that you're intentionally doing it wrong. It could be wrong frequency, wrong diet, not exercising, not enough vitamins and supplements, all sorts of different issues that way. I had one patient who had unexplained infertility who I couldn't figure out. Like I tried everything. And then finally I said, can you tell me about what's happening when you have sex? And so she said, I said, are you lying down and tilting your pelvis up? She said, no. As soon as he ejaculates in me, I get up and I run to the bathroom and wash it out. Well, that's not unexplained infertility. That's definitely a problem with evacuating the ejaculate before it even has a chance to get in you. So sometimes it's just a misunderstanding of timing, of frequency, of health habits, all of that stuff. For everybody else, a lot of the times it is endometriosis or something about your insides we don't know, whether it's infection, previous infection, uterine infection, or you've got endo or tubal damage or whatever. All of those are possibilities.
I'm 36, just had a second egg retrieval, but both eggs disintegrated before fertilizing.
Oh.
Do you think it's still possible to get pregnant? Keep with IVF or try naturally? DOR, POF, low AMH, 0.1 NG.
Yeah, so first of all, I'm really sorry. That's a tough thing to go through. So you can keep trying. The problem is with a AMH that low, your chances are understandably low. Your ovary is working like someone who is about to go into menopause. And at that phase of your reproductive career, the quality of your eggs is going to be very, very poor. So it's questionable as to whether it makes sense to go on trying your own or not. I certainly wouldn't take tons of meds. I would try natural cycle IVF, as I mentioned earlier. I think that's a reasonable approach to things, but I would not take tons of expensive medications for that. Interestingly, as I was preparing for this week's, I'm going to drop a little bit of a bomb here. So as I was preparing for this week's Fact or Fiction, I did come across a study done by a group with Richard Scott in it, and Richard Scott is the holy grail of all things fertility, where they looked at injecting PRP, platelet-rich plasma, into women's ovaries. And these were all going into women who had very poorly functioning ovaries, including those who had premature ovarian failure. And about 8%, up to I think 10%, actually were able to conceive after the PRP injection. So I am going to look at it again. I've never been a believer in it because up until that study, no one has ever demonstrated benefit. But they actually looked at several hundred women and suggested that it was beneficial. Having said that, it's not a randomized controlled trial, and I'm planning to call Dr. Scott and see if he's doing it, or email him and see if he's doing it, because I'm still not a believer, but it may be beneficial for you. Barring something like that, either do natural cycle or consider using a donor, but definitely speak to your fertility specialist and see what they can do to help you out. Did I mention opening an office in the US? Yes. So come summertime, we will likely be opening in the Midwest, and hopefully spreading from there. So we're aiming to do that as long as COVID doesn't stop us. But I am working hard on getting a visa so I can get that process started. Yeah.
Would you recommend PCOS women who get pregnant to continue with metformin, and for how long?
Yeah.
To reduce miscarriage?
So the miscarriage data is confusing. There were studies that showed that it decreased it, and then there was actually one study that showed that it increased it. However, it does reduce the chances of gestational diabetes, and to the best of my knowledge from all of the studies I've seen, it doesn't appear to have any side effects. So I would say stay on it, because if it's going to prevent gestational diabetes, that's protective overall for you and for your baby, and that's a good thing. Yeah, so we keep our patients on it when they've been on it.
I'm 35 and just found out I have PCOS. I have been regular periods, 21-day cycle, and have been using an ovulation stick, which has been predicting ovulation days, but no pregnancy. Are the results fake?
So 21-day cycle.
21-day cycle.
Yeah.
And
using an ovulation kit.
Stick, yep, which has been predicting ovulation days, but no pregnancy. Are the results fake?
So if you have regular ovulation, you probably have very mild PCOS, although if you're having periods every 21 days, that's very close together. Those are actually patients where we use letrozole to lengthen your cycle so that the lining of your uterus and your egg have a chance to kind of line up. Because if you're a 21-day cycle, you're actually releasing your egg on day 7. On day 7, if you've had a 4 or 5 day period, there is no way your lining is ready to accept an embryo. So what you want to do is lengthen your cycle to get it closer to a 28-day cycle, so that the lining of your uterus has more of a chance to mature, so that when the embryo lands in there, it's landing in a lining that is ready, rather than landing in a lining that hasn't had a chance to really fully develop and mature. Take a couple more, we're past 9.
Yeah. Do you have any practices in Toronto?
I do. So I work out of Create, and I'm also working out of IVF Canada. So we have practices in Toronto. You're more than welcome to see us there. You can get referred to us at IVF Canada, or you can be referred to me here in Windsor, and we do it all by telephone, and then I get you monitored there. So no problem, we can do it through any of our offices or operations.
Hi Doc, I have Hashimoto's hypothyroidism with high antibodies, 600 plus.
Oh.
I've always been subclinical with my hypothyroid, taking 50 mcg or Synthroid.
Sure.
I have a full round of IVF with 2 embryo transfers.
Okay.
Day 3 with no pregnancy. Could my antibodies be hindering my success? Also positive MTHFR, low AMH, and anti-phospholipids.
Phospholipid? Oh my God, wow.
Meds at all.
Okay, so you got a lot going on there. So that's a very complicated situation. So that's very brave of you to share all that with us, first of all. So thank you for sharing. Hopefully the team will throw up some likes for you. And let's show her some support. So that's a ton of things going on. So antiphospholipid antibody syndrome makes it much harder to get and stay pregnant. MTHFR can also do that as well. And then on top of that, the other problem that we run into is that you've got these thyroid antibodies. All of those are independent risk factors for miscarriage. That's a scenario where, while we can try to get you pregnant on your own, we actually have to think about doing it with a surrogate as well. Are we losing the camera?
No, it's just like your times. Very good. Go ahead. Can keep going.
Well, no, we're done. Actually, that was the end of that one. We should probably wind it down anyways.
Okay.
Do you have a lot more questions?
You have
A gazillion questions. Okay, guys, it's 9 o'clock. So I'm going to wind it down tonight. Sorry for the technical glitch on Facebook. My apologies, my friends. We will figure that one out and hopefully get back to you guys. In the meantime, have a very safe week ahead. I wish you all the best. We're embarking on our IVF week, so retrievals start Wednesday. And it's busy this month. We have over 25 cycles. So thanks to all of you who are participating. Thanks to all of our patients and our wonderful staff. And we will see you again next week on Fertility Fact or Fiction. Have a great night, guys. Take care.